thank you very much for this nice presentation. Do you have questions?
I think it was a wonderful talk, and what you call the reverse triggering it's really interesting. I mean, we've seen it a couple of times in our study as well, and well, we didn't give it this term, but it's a really interesting observation. I mean, can you speculate a little bit about how the ventilator can trigger a neural inspiration? Are there any pathways you could speculate upon?
At the present time, we have no clear answer to explain reverse triggering. There are many hypotheses regarding the neural feedback we discussed this morning, but we don't know exactly. We are currently testing the influence of peak flow, the influence of the inspiratory time, the influence of a pause during mechanical ventilation, and the only thing we observe is that this reverse triggering entrainment is probably more frequent than we previously know, because when we look at our traces, we look a lot of reverse triggering, and maybe that occur in a part between controlled mechanical ventilation and spontaneous breathing activity. Maybe there is a relationship with the level of sedation. I don't know exactly, but we observe that sometimes a patient starts with reverse triggering for a long time and then switch for normal assist control ventilation. Maybe it's due to a change of its neural control of ventilation from initial control mechanical ventilation to spontaneous. I don't know exactly, but...
Further questions? Yeah.
I know Rolf Hoodmeyer did a lot of work on this many years ago, 25, 30 years ago. And do you see, I know you don't measure FRC, but do you see any connection with that you have the feeling that the patient will have a low FRC and that is doing the reverse triggering, as you call it?
A relationship with FRC?
Yeah.
Maybe, because what we observe is reverse triggering. We write a first paper on 7 patients with acute lung injury, with probably big alteration of FRC, and this is 7 consecutive patients with acute lung injury, or all of these patients at a time after the initial phase exhibits reverse triggering and entrainment. Maybe there is an influence of PEEP level on pulmonary.
It might be a protective reflex that the FRC is going down very drastically, and then you try
maybe.
to...
Yeah, thanks for the nice talk. Have you tried to, when you see that thing, have you tried to reduce the mandatory rate to see if this keeps happening? Because probably the ventilator is coming earlier than the patient wants.
Yes, we try to reduce the ventilatory rate and to increase it. And I don't show the data, but the rhythm of entrainment is follow exactly the respiratory rate we set on the ventilator, exactly. The phase angle, which traduces the occurrence of the spontaneous activity regarding the volume, didn't change when we changed the respiratory rate.
Thank you. But how can you be certain that the trigger has not been activated by another muscle?
Because we record not only the electrodiaphragmatic activity, but also the esophageal pressure. And during the initial phase, there is an increase in esophageal pressure due to passive inflation, so there is no activity. And the other point is the regularity of the occurrence of the spontaneous breath after the initiation. If you perform a pause, then you switch exactly the spontaneous.
Have you any further questions? No? One short technical question. You showed this nice curves of the esophageal pressure. Do you put the catheter in your patients with NAVA in your daily clinical practice, or only for research purposes? Do you guess it's okay with 2 catheters in one patient and all with a balloon in it? Is there any disturbance?
No, we don't use NAVA on this patient. It's because we try to compare RPRV in IRDS and pressure control mode of ventilation. And during RPRV, I will discuss that tomorrow, we observe that there is frequently a breath after the inflation of the pressure at the high pressure level. And to understand that, we observe by chance this phenomena.
Does anyone use both catheters in one patient that you can measure the esophageal pressure and the NAVA catheter? Okay. Good. It's an important question for research purposes, I guess. Okay, then if you have no further questions, we go on to NAVA during sleep. Difficult topic in the ICU, to Walter Verbrugge from Belgium.